for the gift of being here today. My talk is going to be on the integration of promotoras in really in reducing cardiovascular stroke and stroke, but also really in the integration of them in whole life. And I hope you consider it that way. I wanted to share that my work with Promotoras started about 15 years ago. It really started with my family. My mother, as it ended up, was a promotora, but we didn't know that term when she was around. And my grandmother was a curandera. She was the local healer in San Bernardino. So I grew up in San Bernardino in the days when we had segregation and lived in my barrio where we were with blacks and browns. And we had natural healers. We had our like my grandmother who took care of us from burns to whatever chronic disease she could do. She had her potions and her lotions and her things. I don't even know what she had. But she was the one that everybody went to. Ironically, I ran away from that and worked for the county health, for the State Department of Health Services as a manager, and then worked for the county, San Francisco City and County as a manager in the AIDS office, as an administrator. So I call myself a recovering bureaucrat. Maybe you get that. I love the term because every now and then, now that I'm in community, every now and then, I forget to think like community, and I start thinking like a bureaucrat. And when I do that, promotoras come to me and they go, Maria, no, stop doing that. And I fall off the wagon and I have to get back on. So I said it's a recovering bureaucrat, because to think in community ease is very different from thinking in bureaucrat ease. And so hopefully today I'll be able to share with you a little bit of both worlds. The other reason why this movement, the promotor movement, which now has become a national movement, because you can see it in health reform, is my mother passed away from a massive heart attack that was really brought on through many, many years of high blood pressure, of diabetes and arthritis. And she was this really tiny little Mexican woman who spoke no English. So to the day she died in the pre-op room with a massive heart attack, she had gangrene up to her knee, and no one could talk. No one could explain what was going on. No one could comfort her as she was going through this. So part of it is very personal to me also. It is what should have happened to my mother. But what I'd like for you to think of as you're listening to this is think, what would you like for your mother? How would you like your mother to be cared for? Mine can speak English, maybe yours possibly do, but think about the care that you would like to move out of your profession a little bit and think about it more in terms of, well, how would you like your mother to be taken care of? That's what I think of. What would my little mother, who didn't speak English, I remember we were in something and she needed care. I said, Mom, I'm going to go get the doctor, for the nurse. And my mother said, Madre no, to my family, no, leave them alone, they're busy. So I could not go get a nurse for her because she thought the nurse was too busy to care for her. That's just a little example of the cultural piece that we're dealing with when we talk about patient adherence and care. So who are we? Who are promotores? Well, Vicente Compromiso was established in 2001, and we're a statewide, soon-to-be national network of promotores. We bring together promotores in whatever area that they're working with or affiliated with. We're in now 13 regions across the state, from Arcata to border to border, Arcata to Pearl and San Diego. And the way we function is we establish regional committees. So we bring together promotores, community health workers, whatever title, in a self-governing forum where they determine what their needs are. They come together, they do a community assessment based on what they believe the issues are. Now that assessment may be concurrent with an assessment that the county has completed, or may be concurrent with the state assessment. It may be concurrent with others, or it may be different because it is based on what they believe the issues are. But oddly enough, the promoter model was not born here. In the 17th century, we talk about the lay people in the Feldishers in Russia, in China in the 60s, and this was very popular with the Barefoot Doctors movement. In Latin America, of course, we know that we think that's where they came from, but really they didn't. They've been around for a very long time. And in the United States in the 50s and 60s, and those of you that have been around can remember the war on poverty, where we really had kind of a similar activity. The World Health Organization in '78 really looked at local community participation, primary health care, preventive medicine. So the discussion has been going around the medical and community for a very, very long time. But it's not until health reform that you really see an emphasis on it. So who are community health workers? I don't know why this thing is up here, if it doesn't get in the way. So we know that over time, we've been called the natural helpers. We've been called those who are the bridge to communities. When I came into the movement in 98, 97, we were mostly volunteer. Promotoras were mostly volunteers, moms and dads. We know that they increase access to health services, they improve quality of care. Some of this here, the second paragraph really talks to studies that have been developed throughout the United States. There's a lot of literature about promotoras and community health workers saying that they increase access, improve quality of care, reduce healthcare costs. But what we really talk about when we talk about promotoras is the natural helpers piece. And they draw on their insider status, which means that if I'm from San Bernardino and I'm going to work in outreach in San Bernardino, because I'm from there, I probably know where to go. I probably know who to reach. I know what places to go. I know what churches to go. I know what fairs to go. I know what activities. And they'll let me in the door because they know me. Promotores are the ones that really are going to, that are well respected. They're the language and cultural brokers, and they're the ones that are going to get the information into the community. They're sought after for advice and support. The piece that's important here is the servicio de corazón. So the way that I define a promotora, there is a definition with the American Public Health Association. There is a definition with the Department of Labor, and there are various organizations who define promotoras. But the way promotores define promotoras is the servicio de corazón, the espíritu de servicio, which means the heart. A promotor is a person that is almost born with that ability. It's not something that you go to school and you learn how to be kind and thoughtful and helpful. It is those natural helpers. That's why it's emphasized throughout this. So the espíritu de corazón, my ability to want to help somebody. If I want to help Jerry, I'm going to help him because I want to help him because we get along. Not necessarily because somebody pays me. Let's say I'm in the middle of a discussion and it's 5:05. I'm going to go because that's maybe time and a half. So we cut it off. But if I'm a promotora, it's 10 o'clock, we're still doing it, right? Or I go see it at 7 o'clock in the morning. I'm usually an example. The espíritu is really right here. And the espíritu is in everybody. So think of your mother, think of somebody in your family that has that spirit of service. It could be your aunt, it could be your uncle, it could be your grandmother, it could be Jewish, it could be African American, it could be Russian, it could be Somali. There's always somebody in our culture, any culture, every culture, that has this piece right here. And that's when people talk, when you look at the characteristics of promotor, that's what they talk about. And so it's important to understand that piece as we start discussing community health workers and promotores, and that they're not the same activities, nor are they the same people necessarily. And as we start looking at implementation and integration, who are we talking about? Now let's go back to my mother. My mother, this little tiny Mexican woman who didn't speak English, went everywhere, did everything for everybody. Now let's say Jerry has a position for a community health worker, but he wants her to speak English, he wants her to have a high school degree, and he wants her to be able to write reports. It's not my mother. The day she died, she didn't speak English. But she could do everything else. Now, who are we working with? What do we want? And that's part of this discussion is who are promotores and community health workers? How do they fit into your organizations? And how do you get to that point where you're able to really work with them, either inside or outside the institution? So also, promotores, they're flourished throughout California. That means that promotores in the United States have been around for a very, very long time. This is not new. It's new to you. It's new to the system. It's new to the United States, and it's new to health reform. But promotores have been around for many, many, many years. And promotor programs have been around in California probably since the 40s. in an organized fashion, when I found out, probably since the late 50s and 60s. They do vary according to funding. The second paragraph was important because in the past, promoter programs have functioned in a siloed manner because of funding. So let's say the endowment is doing a diabetes piece, wellness is doing a domestic violence piece, and somebody else is doing something. And so you've got all these silos of promotoras working, maybe possibly in the same community. Maybe they're all working in, look at how many people, how many organizations are working in Chula Vista right now. They're like falling over themselves. I'm sorry, it's like these groups that are there, forgetting about the rest of San Diego County. You know, the BHC thing is great, but there's a lot of other county left that they have to deal with. So you've got all these promotoras that are working in these siloed communities, and they never talk to each other, they don't interact because of the organizational requirements or the funding requirements. So the titles and activities vary according to funding. They're involved in everything. They're in mental health, in hospice, in chronic disease, in schools. There's such a diversity of work that promotoras are in. And that's when we say promotoras can be any of these. It's really determined by the funding requirements. So a community health worker, when I was working in the AIDS office, we had CHOWs. I don't know if any of you remember the CHOWs, community health outreach workers and children. And they were really clear. They were the ones that did the outreach, but they were $35,000 a year, they had benefits, they had very specific requirements to work as CHOWs. Over here are the ones that I met in 98. 97. The ones who were working because they wanted to, they would drop off their kids, they would volunteer, they'd do outreach, they'd be out in the field. They were really doing it because of the espíritu del corazón. And then you have everybody else. In 1990, this was done actually like around 2001. But in 1998, 97, this was a very black and white world. You either worked or you didn't. When we started the organization and had a convening in 2001 of leaders, they were very critical of those who got paid because philosophically, are you a promotor if you get paid? Well, it was you are, you aren't. Now, it's a very gray area. So there's a mixture here, and that's why you hear the definitions in health reform saying language that's like a promotor. But really, can you get to that point? And that's part of the discussion within the organization as we sit at the policy table with the health exchange, for instance, or at CMS or at CDC saying, well, what is it that you want and how do you want to do it and how can we help you get there? We do know that there are diverse characteristics. Now, this was defined in 2002. All of that you're going to see here is defined by our network of promotores. These are leaders who are working in the community who say, this is the world of promotores and community health workers. And they make a distinction between a community health worker and a promotor. Now, true, there is more gray area here, but still, you have the community person that in the old days was really given stipends. Remember the days when they would get gas cards or they'd get a $25 card for something. And then there was the institutionalized person. And oftentimes, this community health worker, institutionalized person had to be a BA or an MPH that would supervise these over here. But these are the experts. And so it creates a hierarchy, an informal social hierarchy in the community because of not promoting the promotora, who we call the veterana, the veteran expert promotora who's been in the community for a long time. If Jerry requires her to write reports and do those things, but she's not able to, well, what do we do? In the past, you would hire a BA to supervise the promotoras, and what we say is, well, why don't we look at it a little bit differently? So all of our staff are Spanish-speaking expert promotoras. I don't require them to do all the technical writing. I hire an MPH or a PhD part-time to do all that. So I don't substitute. I recognize the organization, we recognize them as the leaders, and then work creatively to give all the reports and do all the data analysis that we need to. But it is a big difference here. They're employed full-time. We did a survey a few years ago in Los Angeles County alone, and the majority of promotores do not have health insurance themselves. These are the men and women who are out doing this work. I bet if we did a survey here, we'd find out the same thing. They don't have health insurance. Remember, they're probably not working part-time. They're probably working less than part-time because over 20 hours you have to pay benefits. I know that because we employ a lot of promotores. And we try to get around that. But in the end, we have to employ and pay, at least pay benefits, not the full round of benefits, but at least into PPD. And so this is a big distinction. They may reside outside the community, which means they don't really know it. They're driving in to work in a community that they don't know. Therefore, they don't have the recognition or the credibility and it takes them longer to get the job done because they don't know who to go to. They don't know to go to Jerry for something. Instead, they may go to Liz, and Liz may not know how to get there, and so it doesn't get the same result. The methodology for a community health worker and a promotor is different. A promotor is centered typically on a popular education model, which really looks at an integrated ecological approach to health issues. That's a really important piece. We have a little 4-minute video that we took at one of our meetings where promotores give an example, and they say, a doctor comes into, or my child will go to the doctor, and the doctor will say, you have asthma, and they give them a pill. And they say, but promotores rather look at the causes. They go out in the community and find out, well, why does this child have asthma? Well, it could be environmental, it could be all these things that we're talking about now, the experience of health promotores have been doing for years and years and years. Look at this. This was developed in 2003. I leave the dates up here because it's important to know how promotores have evolved, and now the systems are catching up with what promotores think in the community. Curricula recognizes and integrates cultural values. It's a community-driven curriculum, so we really stress the left side. Community engagement to identify solutions, as opposed to someone coming in and saying, this is what you should do. Community determines what they're going to do. In the medical model, it really is teaching, standardized curricula, transfer of information. This offends some, and we didn't put this in here to offend, but it really is a white middle class learning orientation, and the medical system is a white middle class orientation. The question is, how do we get people like my mother to work within a white middle class orientation system when she doesn't even speak English? You know, and you look, what's that book? I do something and I fall down. The Hmong book, the book about the Hmong children. I do something and I fall down. I can't remember the first part of it. It was a great study on how the Hmong do not go and get health service because to them it's a whole spiritual turnaround. It's very different. And I remember when we did this, we did focus groups with Hmong in Fresno, and they said when they go to the doctor, they get sick. It's a whole different orientation. Yet we want them to come here. We want my mother to come here and to do it the way it is here because of our cultural expectations. But my mom was like, you know, I don't know why I have to do this. I know why, because I grew up as a Kaiser baby, so I'm oriented to it. And I know I'm formed. I do what they tell me to do. I've been a Kaiser baby since 3 years old. My dad, I just am. My dad was a Kaiser worker, Kaiser Steel worker. He was one of the he also died at Kaiser Steel, so he had embolism there. But what I take from all this experience I had is that the loyalty piece. And so I think for any of us here, whatever plan we're with or whatever system, it is establishing that piece of look. I'm very loyal to Kaiser. Are there others that I could be with? Sure, but I remember the Christmas parties that Kaiser Plan used to have for us. I remember the way that initially they would reach out to us and they embrace us as a community. This is before we were all so many minorities in the Kaiser system, but we were very few then, and very few numbers. We were in Fontana. But I have these great memories, and so my loyalty to Kaiser is there. And if I share one big thing, it is how do you develop that loyalty? It is because I felt that they cared for them, and they cared about my family. And so if Jerry wants me to be part of his system, then I have to feel like he cares for me. Whether he's telling me to take a med or whether he's telling me to come back and see him, if I don't feel that somebody cares about me, I'm not going to go there. If anything, that's like a big take home right there. I want to feel a relationship. Now, I tried this once with a gynecologist, and I was going to all men. I still had a lot of men gynecologists. So I tried a woman, and it didn't work out. Tried a nurse practitioner, and it didn't work out. And then I tried a Latina doctor. She was worse than the men doctor. Because she was so set in being a doctor. and didn't relate to me as a Latina. And I was really disappointed. And I have, so it's not even a cultural thing. It is, how do you relate to each other? The heart, remember? It is the heart. How do you relate to each other? It is not so much a culture. So what do Promotoras do? What's the success? Well, they facilitate access to services, they strengthen the social support disease management. We know that there's studies that have shown that in diabetes, hypertension. We'll talk about cardiovascular stroke, a project we've been doing. And then the workforce piece. That's the big thing that health reform is talking about. How do we get more of racial and ethnic groups into the workforce? Reduce healthcare costs. The ROI is important. I don't know what to tell you about the ROI. That's a medical piece. It is not really a community piece, although we don't want everybody going to emergency rooms because you don't get the best care there or the continuity of care. And so we do want to have a primary provider. We do want somebody that I can go to that knows me, that says, Maria, I really care about you. How are you doing, Maria? Are you still taking your medication? What are you doing? How are you doing? You're going to hit your birthday. What are you doing to prevent? Do you need all the tests? I need somebody like that can talk to me like that cares about me, doesn't rush me through an appointment. And then I leave going, wow, what was accomplished here? And that's where I think you're going to get some of these things, the healthcare cost reduction, an increase in health and screening behaviors. You're not going to increase health and screening behaviors if nobody's there, if you don't get people in the door. And so how do you get us, if I'm representative of Latinos, how do you get us in the door? Especially the Spanish-speaking immigrant Latino, how do you get us in the door? How do you get my mother in the door? She thought everything that was English-speaking was foreign. It was foreign to her, even though she lived here for 40, 50 years. I think our immigrant communities feel the same way. So how do you then bring somebody like that in? The majority of us are going to be native born, like myself. How do you get us in there when there is this community separation of who we are? Even though I was born here, we don't feel part of the system. And so how do you engage us who are native born also? And you look at our numbers, we're mostly going to be native born. Children of immigrants are increasing by huge numbers. Look at the Pew studies. It's really scary to me as a Latina to think that we have so many Latinos who are not part of the system, don't understand the system, and don't have access to it, whether we speak English or not. The health literacy issue is huge. And you can't explain it to somebody. You can't say to even an English-speaking Latina, go and do such and such, if it's not contextualized within their world, that they have very little money, we're in a recession, they don't have a car, they don't have a grocery store near them. Nobody eats, Mexicans don't eat broccoli. It's no, we don't. No. So I'll give you, I use that as an example because it's like everybody thinks that's the natural food. So we did our first, we have a core training called Latina Saludable, and we tested it at Clínica Ole in Napa, which is a farmer-sponsored clinic in Napa. And it happened to be a diabetes group, and we were training them on how to be promotores, how to do education, how to work amongst themselves. So the nurse who brought us in, it was 6 months of 2-hour evening classes. It was really taxing. So she would bring in snacks. She brought in cauliflower, broccoli, and snacks and dip. And for every week she'd bring it, and they would go back, and she says, "Well, what's wrong? They're not eating it." I said, "Well, can you eat broccoli and cauliflower?" and I mean, so we said, "Okay, group, this is all Spanish. What do you want to do?" They said, "Well, we don't." I said, "Okay, so what do you want to bring?" So they brought chayote, they brought nopalitos, they brought their healthy food that was relative to their community. Now I'm a Mexican, and Mexican heritage, I don't know chayote. So it was great for me, but I know nopalitos, and so we started to exchange even amongst ourselves foods that were healthy, that they knew. Nopales were not fried, chayote that was fresh, all these other things. And it was a great learning experience for me too, and for them. And so they started doing a potluck. Every week somebody would bring something that was cultural, that was relevant, that they knew they could eat, that was healthy. And that was a learning experience for me, because I thought, I grew up on canned green beans, and spam. But if everybody learns from each other, which is what we do in the integration of resources, then it becomes a very positive thing. So what else do Promotoras do? Well, we talked about the increased trustworthiness is important for you as providers. Because if you want somebody to come into your clinic, if I don't know you, I'm probably not going to go there. But if a promotora says to me, you know, Liz introduced me to Jerry. Right? So I got along with Jerry. He's a personable, wonderful person. But my getting there was Liz. So that is the promotor connection. How do we get people connected? It is somebody. I would talk to Jerry because Liz said it was okay. But it's the same thing with the promotor. Promotor will say, come to the Vista Clinic. Why should I? Because I've been there. I know Jerry who works there. He'll talk to you. He'll be nice to you. He'll talk to you in a respectful manner, and he'll help you as soon as he can. Because I have made sure that if I'm going to refer them to Jerry, that that's the kind of person that I want to talk to. So they will go there, and they'll say, ayúdame por favor, blah, 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 and Jerry will say, of course, let's see what we can do. Then she goes back to her community, and she says, wow, you know, I had a great experience. Okay, well, Phil, let's go. Okay, then Phil goes, and Liz goes, and everybody goes. It is this, they are the face, so the trustworthiness, and I can't stress these, they seem almost intangible, but they are the most important things to do outreach education and retention, to keep us coming back, get us in the door and keep us coming back. Reduce barriers, all these things. You know, I do a lot of walking around and just kind of, I go places and I just walk around. Nobody knows who I am or what I do. And if they treat me nice or they don't treat me nice, I really know that. And I walk around in jeans and t-shirt most of the time. Because how they respond to me is how they're going to respond to somebody else. You shouldn't respond to me because I'm the executive director of the National Association, blah, blah. You should respond to me because I'm a woman in need, right? Promotoras reinforce cultural norms, reduce barriers, meet the cultural and linguistic needs. Promotoras are not interpreters. They should not be used as interpreters. There's a whole political discussion on who are interpreters, and we do not even want to step into that. They can go into that, but that's not what they are. Provide fair and impartial information, cultural history, encourage participation in maintaining health. That's a big one. A promotor who's educated, who knows about the caring for yourself, who knows about nutrition, exercise, behavior, and now we were talking with Jim about adherence, med adherence. That's like the A-bomb of tools. That's a person that can go anywhere and say to Phil, how are you doing? And Phil says, well, I don't know, you know, I'm not feeling well. Well, what's up? You know, what have you not been doing? And you say he has hypertension. Well, why are you eating the hot dog? You know, and then we go through the discussion. And he says, well, you know, I haven't eaten all day. We start talking about what are the alternatives. But I know the whole scope of what does it mean.